Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. And this is our second part on orthodontic diagnosis and treatment planning. Just to remind you, Chapter 7 from Simon Littlewood and Laura Mitchell 5th edition is our reference. Right. So in our previous talk, we reached to the stage of formulating our problem list and understanding the etiology for our patient. So we said that anything from our examination that deviates from normal should be mentioned on our problem list, and the a decision should be made for each of the items on my problem list, whether to accept, monitor, or treat, and accordingly, the treatment objectives should follow the order of my problem list. Right, so as we said, also pathologic problems must be addressed. We have to have excellent oral hygiene. We have to have, let's say, initial permanent restorations, not the definitive restorations, because the final restorations should be planned at the end of the treatment where we have the final occlusion. Okay. Periodontal, of course, periodontal treatment should be carried out before any orthodontic treatment is started. Developmental problems, on the other hand, ideally we address all the problems on our list, but sometimes there are certain features that could be accepted or monitored. And by prioritizing my problem list, then I can move on to my treatment objectives and then formulate our treatment plan. Usually there is more than one treatment plan. So we have plan A, B, C, Z, etc. And we need to discuss these treatment plans. We need to discuss the risk and benefits, the cost, for example, duration, prognosis, stability, etc. with the patient, and we make the patient-centered decision making. You know, the decision is the part of the decision should be through educating the patient and discussing the options with them. Also, to be able to formulate our treatment plan, we need to visualize the finished results. What am I aiming for? And then think about how to reach the final results. What are the tooth movements that are required, etc. Right. Now, so this is the general list of my problem list. So non-orthodontic problems, skeletal problems in the anterior, posterior, vertical, and transverse. Soft tissue problems, again, anterior, posterior, vertical, transverse. Dental relationship, anterior, posterior, vertical, transverse, and then lower arch, space condition and alignment, upper arch, space condition and alignment. Now, treatment objectives should more or less follow this list, okay? So the non-orthodontic problems, I should always aim to manage, okay, by restorations, root canal treatment, periodontal treatments, etc. Skeletal problems could be treated, maybe accepted, and then we move the teeth around to camouflage, or maybe we can monitor. In young patients who are still growing, some skeletal features could be just be reviewed and monitored. In terms of soft tissues, the same, either treat, accept, or monitor. It depends on the case. Dentally, in the anterior posterior dimension, we usually aim to correct the overjet to the average. We usually aim for the lower limit of the average, which is the 2 millimeters, okay? We know that the overjet is 2 to 4, but we aim to correct the overjet to 2 millimeters. We aim to correct the anterior crossbite. Of course, we aim to correct the canine relationship to class 1. It is always important to aim for class 1 canine relationship unless we have congenitally missing lateral incisors in the upper, and I'm planning to close the spaces by replacing the laterals with the canine. This is the only scenario where we can have class 2 canine relationship because the canine is replacing the laterals. Also, in cases where we have congenitally missing incisors in the lower arch, sometimes the position of the lower canine is disturbed, and this will affect the canine relationship. Otherwise, we should always aim for class 1 canine relationship at the end of the treatment. For the molar relationship, we should always aim for class 1 or full unit class 2 or full unit class 3. Okay, we should never end up with the half unit class 2, for example, half unit class 3, etc. So we need to correct the molar relationship accordingly. The dental vertical proportions, of course, we need to correct the overbite. If it's deep, we need to reduce it. If it's reduced, we need to increase it. If it's an anterior open bite, we need to correct it. Transversely, we need to correct the center line, we need to correct the buccal crossbite, and then regarding the lower and the upper arch, we need to manage space, we need to manage crowding, we need to align and level, relieve crowding, or close spaces if there is a spaced arch. Okay, so as you can see, the treatment objectives really depends on the problem list accordingly. Some features we accept, some features we treat. Now, regarding the skeletal problems on my problem list, we said that we could accept and camouflage, we could treat. What are the options that we have? Either orthodontic camouflage or growth modification or orthodontic surgery. Okay, orthodontic camouflage is to accept the underlying skeletal discrepancy, and usually it's mild or moderate, and then we move the labial segment into class 1 relationship. The smaller the skeletal discrepancy, the more successful and more aesthetic the results will be. Okay, it's easier to camouflage the anterior posterior skeletal discrepancy than the vertical, and it's easier to camouflage the vertical compared to the transverse problems. Okay, so the transverse is the most difficult skeletal discrepancy to be camouflaged. Growth modification, we already covered this when we talked about growth modification and functional appliances. Okay, so if the patient is still growing, we can use growth modification. So this option only applies to patients who are still growing. What am I aiming for? I'm aiming for either enhancement of forward growth of the mandible using functional appliances in patients with a class 2 skeletal pattern and retrognathic mandible. Or we can enhance the forward growth of the maxilla in patients with retrognathic maxilla class 3 skeletal pattern. Growth modification results are still questionable. So far, the evidence tells us that the results are usually minimal. So it's important to work according to this, let's say, evidence or this piece of information. In the growth modification mainly address the anterior-posterior discrepancy, rarely has an effect on the transverse or the vertical dimension. The choice of appliance depends on the type of skeletal discrepancy and type of malocclusion. Combined orthodontic and orthognathic surgery is mainly for patients with severe skeletal discrepancy in the anterior posterior, vertical, or transverse dimensions. Okay, if the patient, and of course, most importantly, not only to have severe skeletal discrepancy, but also to have a patient who is concerned, aware of the problem, and demanding correction of such discrepancy. Some patients with severe skeletal discrepancy or moderate skeletal discrepancy, they would say, oh, we're happy with our profile. I just want to straighten my teeth, for example. So it's not always indicated for patients with surgery with severe skeletal discrepancy. It's important to discuss different options with the patient. And of course, in contrast to growth modification, we said that growth modification is mainly for growing patients. Okay, now orthodontic surgery is mainly for fully grown patients, for adult patients. So it is mainly an option for patients where growth modification is it is too late for them to have growth modification, or camouflage cannot produce good aesthetic due to the severity of underlying skeletal discrepancy. So it's an important option to discuss with the patient, and this is how we can correct some skeletal problems. Right, so once we prioritize our problem list and reach our aims, we discuss the options with the patient, and then we get consent, and we end up with our definitive treatment plan. So at this stage, we know what the problem is because I have my problem list. I know why this happened because I thought about the etiology and I decided on my treatment objectives. Now I need to decide on my treatment plan. To be able to decide on our treatment plan, we answer these questions. But first, we have to talk about The basic principles in orthodontic treatment planning according to the chapter that you have as a reference. Okay, and this will answer most of the questions already, but we need to start with this. Okay, oral health, lower arch, upper arch, buccal segments, anchorage, treatment mechanics, and retention. Oral health, as we said, we should never start orthodontic treatment unless we have good to excellent oral hygiene. We need to have good tooth quality. We need to have the permanent restorations. Um, I'm not talking about the final definitive restorations, but at least not, we can have amalgam, we can have composite, but not this temporary restoration. This is not acceptable. So all non-orthodontic pathologies should be corrected first. And after that, we always, during orthodontic treatment plan, we start in the lower arch. And this is the traditional way to do it. We plan our lower arch first, and then we build our upper arch around the lower arch. This is the traditional way to do it, okay? And the reason why we used to do this, because the lower labial segment is actually positioned in a very narrow zone of equilibrium or balance, sitting between the tongue and the lips and cheeks, with very thin plate of bone covering it lingually and labially. So we try to aim to minimally change the position of the lower incisors anterior-posteriorly. Okay, the best thing is to leave them in place. Otherwise, if there are going to be any changes, it has to be minimal. Any excessive movement of the lower labial segment is prone to relapse, and it might affect the gingival health and cause periodontal problems. Now, on the other hand, the contemporary way of thinking is to plan the position of the upper incisors, because the anterior-posterior position of the lower incisor does not always guarantee good aesthetics. Okay, so the new or contemporary way of thinking is that if the lower arch can be maintained in its current position without compromising aesthetics, so we decide to maintain the anterior-posterior position of the lower incisors, and if I build the upper arch around this position, I will still have good aesthetics, then this is the best approach. However, in some cases, the stability of the lower arch can need to be compromised in order to allow a better positioning of the upper incisors and maximize the aesthetics. Okay, all these options and explanations has to be discussed with the patient. Okay, so this is very important. We always aim for the traditional way to plan our lower arch unless this would compromise aesthetics. In this case, we prefer to compromise stability in the lower and enhance aesthetics. So we said that we need to maintain the anterior-posterior position of the lower incisors, but there are some exceptions. We can procline the lower incisors if we have mild lower incisor crowding, and we're going to procline the lower incisors minimally in order to relieve crowding. In cases where we have deep overbites, usually in class 2, division 2 cases, where the lower incisors are trapped behind the upper incisor and behind the palate, right? And this is why we can procline the lower incisors in this case, because the incisors are not positioned in their natural balancing zone. They're being trapped. So we need to reduce the overbite and procline the lower incisors in order to achieve the balancing zone. Patients who had digit sucking habit, of course, thumb sucking habit will force the lower incisors lingually. Again, this is not the natural balancing zone. So we stop the habit, and then we can procline the lower incisors into their in a balancing zone between the lips and the tongues. To prevent unfavorable profile changes in patients with large overjets. We know that an increased overjet can be reduced to the normal by retroclining the upper incisors, but sometimes only retroclining the upper incisors can lead to unaesthetic and unstable position of the upper incisors. In these cases, it's better to have a combination of proclining of the lower incisors and retroclining of the upper incisors in order to achieve a reduced and the normal overjet. Other clinical scenarios where I am allowed to retrocline the lower incisors are two clinical scenarios, mainly patients with mild class 3 malocclusions, where I need to camouflage the malocclusion by retroclining the lower incisors, and cases where we have bimaxillary proclination, where I'm aiming to retrocline both upper and the lower incisors. Okay, so if the anterior posterior position of the incisors is compromised, we need to talk about sometimes permanent retention. Okay, it's never acceptable to compromise the position to the extent that we compromise the oral health, for example, leading to gingival recession or bone dehiscence. Okay, we can compromise stability, but not oral health or function. Now, after I decide on the anterior posterior position of the lower incisors, I need to look at the space requirements in the lower arch. How much crowding do I have? Rotations, how much transverse changes is needed, flattening curve of speed, distalization, or mesial movement of teeth. It's important to look at the space required. We have the contemporary extraction guidelines, and you need to remember that this is only a guideline, okay? It's not like a must. So if the space required in the lower arch in order to align and level and normalize the teeth is 4 millimeter or less, then we rarely need to extract teeth. If it's 5 to 9, we try to avoid extraction of teeth because this is a borderline case, and we try to find other methods to provide space, like, for example, expansion, distalization, proclining lower incisors, interdental stripping, etc. And we need to look at other features for our decisions, especially those related to soft tissue features. If it's more than 10 millimeter, then most probably we will need extraction. Again, this is a guideline, and we need to look to other methods to provide space. After I decide on my lower arch in terms of extraction, in terms of the lower incisor anterior posterior position, now I will have a clue about where my lower canine is going to be positioned anterior posteriorly. And then we move to the upper arch, and I try to visualize the position of the upper canine in order to achieve a class 1 canine relationship. So I need to build the upper arch around the planned position of the lower arch. And the key of success here is to plan the canine into class 1 relationship. Okay, so once I do this, once I mentally reposition the maxillary canine according to the new position of the lower canine, then I will have a clue about the type of movement, the amount of tooth movement required, and then I can manage and decide on my anchorage and on the appliance, type of appliance I'm going to use, and the space requirement. So again, visualize the canine into class 1, decide on the space, the requirements in the upper arch in terms of crowding, in terms of overjet, in terms of molar position, canine position, and then decide on extraction. Decide on other methods. If no extraction, then decide on other methods to provide space. And after all this, you have to decide about your molar relationship. So the molar relationship will depend on your extraction decision. If you decided not to extract at all, you have to aim for class 1 molar relationship. If you extracted in the upper arch only, then you plan for full unit class 2 molar relationship. If you extract in the lower arch only, then you have to plan for full unit class 3 molar relationship. If you extract in the upper and the lower, and here we're talking about premolars, of course. If you extract in the upper and the lower, then you have to plan for a class 1 molar relationship. So the buccal segment relationship will depend on your extraction decision mainly, okay? Usually in class 2 malocclusions, we extract in the upper arch mainly. In class 3 malocclusions, we extract in the lower arch mainly. And of course, the guidelines for extraction depends on the case. So again, if there is no extraction, then it's a class 1. Extraction in the upper arch only, it's a full unit class 2. Extraction in the lower arch only, it's a full unit class 3. Extraction in both arches, it's a class 1 molar relationship. Okay, so this is a case where we have no extraction in the upper, no extraction in the lower. You can see that the canine is beautifully class 1 and the molars is beautifully class 1 on this side. This is another case where we have extracted premolar on the upper right quadrant and extracted premolar in the lower right quadrant. So obviously we need to have a class 1 molar relationship. On the left side, if you have the same extraction pattern, then of course you need to aim for class 1 molar relationship. But on the other side, if you have different extraction pattern, then it depends on the extraction pattern. Another example, this is where in the upper right quadrant we had extraction of a premolar, in the lower non-extraction, so you can see the canine is class 1, but the molar is full unit class 2, and this is the ideal molar relationship if you extract it in the upper arch only. And of course the opposite is true if you extract in the lower arch only. Now, Anchorage, as you remember, is resisting unwanted tooth movement. And every time you move a tooth, this is an action. Every action has a reaction. So sometimes the reaction is considered unwanted tooth movement. So you have to resist this. You have to think about it, okay? And you have to decide on this before any start of a treatment as you plan. You took a whole lecture about Anchorage, so it's important to think about it because it's the most difficult area in orthodontics to be decided. So bodily movement compared to tipping movement will require more anchorage. Patients with increased vertical proportions, usually space closure is easier and loss of anchorage is easier, so you have to reinforce anchorage compared with patients with reduced vertical proportions. If you extract teeth and more than half of the extraction space is needed, then you have to reinforce anchorage. Tooth movement in the lower arch is more difficult than movement of teeth in the upper arch, so comparatively, you need to reinforce anchorage in the upper arch compared to the lower arch. So it's important to decide what you're going to do for anchorage. Do you need to involve more teeth in the anchorage unit, for example, banding the sevens? Do you need to add lingual arch, nance, or transpalatal arch? Do you need to use headgear or maybe mini screws? So you have to decide this according to the type of tooth movement, amount of tooth movement, appliance to be used, etc. Appliance to be used, okay? It is a decision that should be made based on your treatment objectives. You need to choose the appliance that will fulfill your treatment objectives, and that is the best choice for the patient in terms of minimal compliance. And it's important to discuss with the patient the different treatment mechanics and types of appliances. In the lack of high quality evidence, the choice of appliance will rely on the clinician's experience, okay, and preferences. But it's extremely important not to choose the appliance first to determine the treatment aims. The best saying that to describe this is, if all you have is a hammer, everything eventually will look like a nail for you. Okay, so if you are only good in using appliance A, for example, orthodontic appliance A, then you want to fit this appliance for every patient. So you try to customize the treatment aims based on the use of this appliance, and this is wrong. Okay, the appliance system and the treatment mechanics should never be used to determine the treatment aims. You decide on your treatment aims first, and then you choose the appropriate appliance. Okay. It could be functional appliance, it could be fixed appliance type A, type B, type C, whatever. Okay, so it's important not to limit the appliances based on your limited expertise and use it for every patient. Right, as we said, we have functional appliances for growth modification. We have removal appliances for simple tipping movement or overbite reduction or movement of blocks of teeth, and fixed appliances for bodily movement and the 3D control of the position of the teeth. Treatment duration and expected prognosis will again depend on the my treatment plan. If you're using removable appliance, then you can expect 1 millimeter of tooth movement each month. If you're using fixed appliances in simple cases, you expect 1.5 years to 2 years max. Cases where you have impacted teeth or extraction of molars, then usually it's 2 years to 2.5 years. It takes longer time. And you should always overestimate the time as you discuss this with the patient. Take into consideration holidays, breakages, and failure of attendance. Now, Regarding the prognosis and stability, it's important to consider different factors: soft tissue, skeletal, and dental. For example, soft tissue, for example, reduction of overjet, the stability of reduction of an overjet really relies on achieving competent lips, for example. Skeletally, if the patient is still growing, then a class 3 skeletal pattern should be kept under review because it might get worse and you might have relapse. Dentally, good occlusal digitation might enhance the stability, so you should always aim for good digitation. Otherwise, you need to consider this during your retention stage. Retention stage is a must for every patient. So before you start any treatment, you need to discuss this with the patient. The patients who are unwilling to go through retention stage do not start treatment because they will not be satisfied. They will end up with good occlusion and then it will relapse. Okay, the choice of retention will depend on type of tooth movement at the end of the treatment. So if you bring me a patient who has finished his treatment and they want to remove their appliance and I didn't start their treatment and you ask me about the retention regime, I will never know. I cannot make a decision. I need to see exactly where the patient started from, what type of tooth movement, what type of appliance the patient had in order to be able to decide on the retention regime. Generally speaking, every case needs retention, okay? We usually use simple retention, vacuum formed retention for the upper and the lower arch. We ask the patient to wear them. We ask them to wear them for the rest of their lives due to the different changes in the occlusion that will be expected later on, even not related to relapse. It's related to occlusal, what they call maturation of the occlusion, aging of the occlusion. Okay, and this is the new trend now, or the new thinking now, is to have retention for life. Okay, retention for life to avoid relapse. Some difficult cases that are prone to relapse, we use sometimes bonded retainers, but it's important to discuss this with the patient before we start. So the retention could be fixed or removable, short-term or long-term, and it depends on the treatment that was carried out. Okay, so now we can answer these questions. Shall I treat or not? Shall I treat or not? It depends on the risk-benefit analysis. If the risk overweighs the benefits, then we do not treat. As we said, patients who are unwilling to go through retention stage do not treat. Patients who are refusing the treatment or complying with the appliance that you are using do not treat. Patients who cannot maintain excellent oral hygiene, again, do not treat. Patients who are really lacking proper motivation, again, be careful, do not treat. Patients with unrealistic expectations, although you try to educate them and talk to them, again, do not treat. Patients with very, very mild malocclusion, where the risk, again, overweigh the benefits, try not to treat. Try to be honest with the patient, try to explain what you can do and what you cannot do. Of course, cost benefit should be discussed with the patients, and perceived benefits should be discussed. Patient's acceptance, motivation, cooperation, psychological well-being, medical conditions, all will affect on this decision. The other question, ideal or compromise. If you're talking about ideal, that means you are looking at 6 keys to normal occlusion, normal skeletal pattern, and normal soft tissue pattern in order to say, oh, this is ideal. Compromise, as we said, is to accept certain features of the malocclusion, and it does not mean at all to leave the patient worse off in the long term. Okay, you should never compromise oral health. You should never compromise function again and again. I need to repeat this really because it's important for you to understand. And here comes what we call, since we're talking about compromise, here comes the terminology LTO, which means limited treatment orthodontics, or short-term orthodontics, or what we call social 6. Okay. This is a treatment of choice for patients, usually adults, patients who are having only limited treatment demands related to aesthetics mainly, where they want to improve their smile. They don't want to go through lengthy treatment. For example, so you have to explain to them that our treatment objectives are limited, it's going to be a shorter duration, and still we will need retention stage after we finish. Okay, so it's important to weigh benefits and risks again, and talk to the patient about any necessary adjunct treatment. For example, patient might need restorations, periodontal treatment, for example, gingivectomy, veneers, etc. So all these aspects has to be discussed with the patient to get proper consent before any treatment. So consent has to be achieved, and we need to discuss all alternative treatments and or adjunctive treatments as necessary. It's not acceptable for limited treatment orthodontics to compromise oral health or to end up with an occlusion that can cause tooth wear, lead to temporomandibular joint complications, or damage to dental restorations. Okay, so it's limited treatment orthodontics. It is compromised, but it should end up with better aesthetics, maintaining oral health, and maintaining good occlusion. Right. So after extract or not, we discussed this, Anchorage, etc. So all these has been discussed with the basic principles of treatment planning. Now, just want to remind you about our examination form. This is the first step, and then we end up having our problem list and our etiology, and then we formulate our treatment objectives. And based on our treatment objectives, I need to think, how am I going to fulfill it by choosing the proper treatment plan in terms of extraction, non-extraction, type of appliance, anchorage, buccal segment relationship, and retention duration. And now we're going to have an example. Okay, so this young patient, 10 years and 5 months patient who is complaining of a buccally displaced canine, as you can see here. She also had her both sisters having orthodontic treatment, and she wants to have treatment the same as them. So just to have a look at the extraoral photos, radiographs, and intraoral photos, we need to look at our problem list. Non-orthodontic problems, obviously poor oral hygiene, some gingivitis at some local areas. Okay. Also, non-orthodontic problems is a retained C in the upper left quadrant, retained D, caries affecting both first permanent molars in the upper, and retained D in the lower left quadrant. So we have retained deciduous teeth and active caries. So this is non-orthodontic problems. This is a problem. Now we will move to the skeletal problems. Skeletal problems related for the patient in the anterior posterior dimension, as you can see here, it's class 1. Convexity of the face is acceptable, is mild. So I don't write anything in terms of the anterior posterior dimension. In the vertical dimension, I have a problem. I have increased lower facial height. I have increased maxillomandibular plane angle, as you can see here. I have increased Frankfurt mandibular plane angle. So this is a problem that I have to mention in my problem list. Transversely, the patient has a good facial symmetry, but intraorally, the patient has narrow maxilla. So you can see that the maxilla is V-shaped, it's collapsed, so that we have narrow maxilla. And also we have increased vertical excess. And this is the etiology of the gummy smile. So all these things has to be mentioned in the skeletal problems. Soft tissues, the patient has incompetent lips and low lip line and gummy smile. Otherwise, nasolabial angle is acceptable, labium interfolded is acceptable, thickness of the lips, etc., etc. The other features are acceptable. Dentally, we have a long list. Okay, in the anterior posterior, although the overdid is 3 millimeters, I have to mention it because, as we said, we aim for the lower limit of the average. We aim for 2 millimeters. So I need to mention that the overdid, although average, it's a 3 millimeter. In anterior posteriorly, also we have both laterals are in crossbite. So this is an anterior posterior problem. Now the canine relationship, the molar relationship on both sides are actually class 1. So I don't have to mention the canine relationship or the molar relationship because this is normal. Now we move to the vertical relationship. The overbite is reduced and complete, and there is no other vertical problems. Okay, the open bite here and the slight open bite here is related to the late mixed dentition. Right, transversely, I have a problem. I have the upper central line shifted to the left about 1 millimeters and the lower central line shifted to the left about 2 millimeters. And we have bilateral crossbite affecting all teeth except for the upper left four. Okay, so all teeth in the buccal segment are affected except for this one. Even the molar is in a potential crossbite. So obviously we have transverse problems. Now we come to the lower arch alone. Lower arch, you can see that we have mild crowding. The D is retained, and the 3 and 4 on the left side are buccally displaced. In the upper arch, we have B-shaped, narrow maxilla, moderate crowding of about 5 millimeters, retained C caries on the sexes. This was mentioned at the top with the non-orthodontic problems. Other problems are related to severe displacement of the upper left canine and first premolar buccally, palatally displaced both laterals and both second premolars. Okay, and as we said, with a 5 millimeter of crowding. Right, now I need to think, since I ended with my problem list, I need to think of my etiology. Okay, in terms of etiology, the non-orthodontic problems, of course, related to poor oral hygiene, poor brushing techniques, sugary diet, and this is related to the active caries. In addition, that the patient is not really giving good attention to having proper visits to the dentist, okay, ending up having these retained deciduous teeth and active caries. So the patient is not really having good dental attitude and regular visits with the dentist. This is a problem. Skeletally, we said that we have in the vertical dimension, it is increased dimension, and this is related to posterior growth rotation. So the etiology is posterior growth rotation. Incompetent lips is related, and low lip line is related to the increased vertical proportions, and the gummy smile is related to increased maxillary vertical excess. Dentally, the crossbite related to the central, to the laterals is mainly due to crowding and displacement of teeth. As you can see, the laterals are crowded and they are palatally displaced. Vertically, we have reduced overbite. The etiology is increased vertical proportions and posterior growth rotation. Transversely, as we said, we have narrow maxilla, and this is the main etiology for such crossbites and crowding in the upper arch mainly. Central line discrepancy is mainly related to crowding more than the narrow maxilla. Now, in the lower arch, the etiology is retained D. The etiology is arch length, tooth size arch length discrepancy. In the upper arch, the etiology of such features is related to narrow maxilla, retained deciduous teeth, and tooth size arch length discrepancy. Okay, so you can see that the majority of the problems is related to the vertical and the transverse dimension. Anterior posteriorly, we have minimal problems. Now, treatment planning. Shall I treat or not? Of course, I need to treat because we have functional benefit for this patient due to the crossbite. We have oral health benefit due to the crowding and the retained deciduous. And of course, there is aesthetic benefit for the patient. Okay, so we need to treat, and we always start with the non-orthodontic problems, as we always said. Okay, ideal or compromised? Well, we're not going to correct the vertical problems. Okay, the maxillary excess, the increased anterior lower facial height, the maxillomandibular plane angle, because the patient is still growing. So we need to accept and monitor. Okay, in terms of the gummy smile, because of the vertical excess, again, we monitor because the upper lip length is not fully developed yet. The patient is only 10 years old and 5 months. So we need to accept and monitor at this stage. Extract or not? Let's look at the lower arch, okay? The lower arch, I'm planning to have minimal changes in the anterior posterior position of the lower labial segment, a little bit of proclination in order to relieve the mild crowding. Of course, the D has to be extracted, align and level. So in the lower arch, non-extraction. In the upper arch, although I have more crowding, but the problem is not related to mainly to two sides arch length discrepancy, but mainly it is related to the narrow maxilla. So if I expand, I will have space, so I don't need to extract. So non-extraction in the upper arch as well, because I have other methods to provide space. What about the buccal segment relationship at the end of the treatment? Since I'm not going to extract in the upper or the lower, then I'm planning to achieve class 1 molar relationship bilaterally. And to be more clear or more accurate, I want to maintain the class 1 molar relationship bilaterally. Okay. Anchorage demands, since I'm not planning to move teeth anterior posteriorly that much, there is no extraction. We mainly, the majority of the changes is going to be transversely. I have reciprocal anchorage. I'm planning to expand, and this will give me reciprocal anchorage, which is enough. So anchorage is under control. What is the type of appliance? If you look here, I have bilateral crossbite, but the amount of expansion necessary is maximum 6 millimeters. So a quad helix for this patient will give us skeletal and dental effect because the mid-palatal suture is still open. She's still 10 years. So I'm going to choose quad helix for expansion and fixed orthodontic appliance, of course, for alignment. Timing of treatment now. I need to start now because, as we said, the mid-palatal suture is open. I'm not going to wait further until it's closed and the expansion is more difficult. Okay. Treatment duration. Well, since no extraction and mainly expansion, we expect about 1.5 to 2 years. What about retention? I aim for good interdigitation at the end of the treatment, but since we went for expansion, I need to think about rigid Howley retainer followed by a vacuum formed retainer. In the upper and the lower, we can start immediately with vacuum formed retainer. Right, so the first stage, non-orthodontic problems, which is maintaining good oral hygiene, restoration of the upper sixes, extraction of the deciduous C, deciduous D, and deciduous D, and bring the patient when the patient is ready with good oral hygiene. And now the patient is ready, acceptable oral hygiene, we would say. So fitting quad helix for expansion, lower fixed appliance for alignment. And this is quad helix as it is progressing with the expansion and lower arches being aligned. And this is finishing expansion. You can see the change in the transverse dimension of the maxilla. Settling of the occlusion. This is improving the overbite. We're trying to increase the overbite as much as possible because of the patient's tendency for vertical growth. And this is the patient at the end of the treatment. So you can see the patient here. Well, we can say that the patient had better, let's say, the patient is more aware of her aesthetics, so she's keeping her lips together. So we still have active pentalis muscle, so this is not perfect, competent lips. Gummy smile has reduced, okay? Maybe the patient is growing and the maturation of the lips and the length of the lips is improving. And maybe the patient is more aware of her smile. But you can see that the risk-benefit, definitely the patient had more benefit than risk for her treatment. Okay, let's take another example. The other example here is a patient who's an adult, 19 years old. His chief complaint is, I don't like my smile. You can see as the patient is smiling, normally we will have full clinical crown showing on smiling, plus minus 1 millimeter of gingiva show is considered acceptable, it's considered normal. The patient is showing almost nothing, minimal teeth show on maximum smiling, nothing. Okay, so the patient has realistic demand. They have a realistic chief complaint. Now, as we examine the extraoral photos, the radiographs, and the intraoral photos, you will see that the patient from non-orthodontic problem list has very poor oral hygiene. Old restorations on the incisors. Okay, some pit and fissure discoloration. The patient is lucky not to have caries and old restoration on the buccal segment, but definitely poor oral hygiene. Now, anterior posteriorly, skeletally, the patient has class 2 skeletal pattern with convex profile. Vertically, the patient has increased Frankfurt mandibular angle, increased maxillomandibular angle, increased lower facial height. So the patient has vertical problem. Transversely, the patient has acceptable facial symmetry. So we don't need to mention this. In terms of soft tissue, the patient has minimal teeth show on smiling, no teeth show at rest at all. So this is a problem, okay? Low lip line, and most importantly, in terms of soft tissue, is the swallowing pattern. The patient has tongue to lips swallowing pattern. Again, this is really an important feature. Now we move dentally. Dentally, in the anterior posterior dimension, the patient is presented with a class 2 division 1 with 9 millimeter overjet. This is huge. 9 millimeter overjet. And the canine relationship is half unit on the right and quarter unit on the left. The molars are class 1, so we don't need to mention this in the anterior posterior dimension. Vertically, the patient has severe anterior open bite of 6 millimeters. And it is extending from the 4 on the left side all the way to the canine on the other side. So this is huge. Okay. Transversely, the patient has lower midline shifted to the right about 1 millimeters and crossbite on both 4s only. So transversely, we really don't have that lots of details. In the lower arch, as you can see, the lower arch is presented with retroclined lower labial segment and severe crowding with multiple rotations and displacements. Severe crowding. In the upper arch, there is moderate crowding with both laterals displaced palatally, and there is multiple rotations, as you can see here. Okay. So this is summarizing the whole problem list that the patient is presented with. Let's talk about the etiology. Okay, so the etiology is, in terms of non-orthodontic, obviously the patient is not brushing properly, they are not visiting their dentist, they're not using dental floss, etc., etc. In terms of the skeletal, the patient is having class 2. The etiology is retrognathic mandible. The patient is having increased vertical proportions. The etiology is posterior growth rotation. In terms of soft tissues, the patient has minimal teeth showing on smiling and at rest, and it is related to vertical maxillary deficiency. There is a vertical maxillary deficiency. Okay, this is not related to lazy upper lip or problems related to soft tissues. It's mainly related to maxillary deficiency. Of course, tongue to lips swallowing pattern, the etiology is the severe anterior open bite. Okay, now dentally, the 9 millimeter overjet and the class 2 canine relationship is mainly, the etiology is mainly related to class 2 skeletal pattern with retrognathic mandible. Vertically, the anterior open bite is related to the increased vertical proportions and the posterior growth rotation. Transversely, the center line discrepancy and the local buccal crossbite on both 4s is mainly related to crowding and displacement of teeth. So the lower arch, we said severe crowding. It's mainly because of the swallowing pattern where the lips are pushed against the lower incisors to reach anterior oral seal. Also arch length, tooth size arch length discrepancy. In the upper arch, we have also tooth size arch length discrepancy in addition to the swallowing pattern. Okay, it is mainly the etiology for this for these features of the malocclusion. Now, what are our aims of treatment? What do I need to correct? How can I prioritize my problem list? Of course, non-orthodontic problems, we need to give oral hygiene instructions. We need to reach excellent oral hygiene. We need to replace the old restorations, and we need to have good motivation of the patient. The good news is that the patient had internal motivation. They wanted to improve their aesthetics, and they are demanding treatment. So this is good. Now, skeletally, class 2 skeletal pattern, maxillary deficiency can only be corrected with orthognathic surgery. So we need to carry out surgery for the patient. What I'm thinking of is posterior impaction of the maxilla. And when we say posterior impaction of the maxilla, that means as if we are rotating the maxilla clockwise. So as if the upper incisors are being retroclined and being brought downward. So this will correct my overjet and my overbite and the incisal show at rest and the maxillary deficiency of the vertical deficiency of the maxilla. Okay, so we are aiming for clockwise rotation of the maxilla and a mandibular advancement by sagittal split osteotomy. So surgical correction of the problems. Okay, So am I aiming to correct these teeth show on smile and twist? Yes. Am I aiming to correct the tongue to lip swallowing pattern to normal swallowing pattern? Yes, because I am aiming to correct the overbite, the anterior open bite into a normal overbite. We are aiming to reduce the overjet to the normal. We are aiming to correct the canine relationship and to correct the anterior open bite, okay? Also, we are aiming to correct the midline and the buccal crossbite on the fours. In the lower arch, we are aiming to align the teeth, and to be able to do so, we have severe crowding. We need to think about extraction. In the upper arch, I'm not planning to retrocline the upper incisors, although they are proclined. And the reason why, as we said, because we are planning for posterior impaction of the maxilla, and this will bring the upper incisors backward as if they were retroclined. So I need to maintain this as a preparation for the patient before surgery. Okay, so having all these thoughts in mind, I need to plan my treatment. So treat or not, of course, I need to treat because the patient has functional need, aesthetic need, and oral health need in terms of crowding. Functional need in terms of tongue to lip swallowing patterns, aesthetic needs in terms of teeth showing at rest. Ideal or compromise, since I'm going to correct the skeletal patterns or preview patterns, etc., then I am aiming for ideal treatment. Extract or not in the lower arch, I cannot avoid extraction. I have severe crowding and I need to normalize the lower incisors as a preparation for the patient before surgery. In the upper arch, on the other hand, non-extraction because I'm not planning to retrocline the upper incisors and I have moderate crowding. So what's the buccal segment relationship at the end of the treatment if I'm planning for non-extraction in the upper arch and extraction in the lower arch only? It has to be full unity class 3 molar relationship. Okay. In terms of anchorage in the lower arch, I'm a little bit concerned because the extraction, after extraction of the fours, I need most of the space to face this problem. We're going to go for suctional mechanics. We're going to bone the buccal segment first, retract the canine first, and then align the rest of the labial segment later. So it's like divide and conquer. Okay. What is timing of treatment? Shall I start now or wait? The patient is 19 years old, already an adult, fully grown. In addition, my treatment is going to take about 1 to 1.5 years. So by the time I end, the patient is an adult that is ready for orthodontic surgery. Treatment duration, as we said, usually about 1 to 1.5 years before surgery and about 6 months to 9 months after surgery. Okay, retention and stability. We need to plan for bonded retainer in the lower in addition to vacuum formed retainer in the upper and the lower. Okay, so this is the patient at the beginning of the treatment. You can see we only used fixed appliance on the buccal segment only. And we did not bone the labial segment. We are retracting the canine first, and after that we can bone the lower incisors. So this is alignment and leveling of the upper arch and the lower arch. And this is, we usually, when we are almost ready for surgery, we take pre-surgical records, cephalogram, OPG, study models, photos, and then we sit with the surgical team and we discuss our surgical plan. Okay, so this is after surgery, and this is patient's profile and smile. After surgery, the patient did struggle with oral hygiene. We tried to go for finishing, and this is the patient at the end of the treatment. Not the perfect result, but at least the patient did benefit from the treatment. We did fulfill patient's chief complaint. As you can see here, I want to show you the full unit class 3. So extraction in the lower arch only, we need to aim for full unit class 3 molar relationship. Okay. So this is how we formulate our problem list, think about the etiology, come out with our treatment objectives, and then plan our treatment. I hope things are clear now, especially after discussing 2 clinical cases. I know it's a difficult topic to study, and it depends on lots and lots of basic information. So you have to have all the basic information in hand, and then you can actually use them to build or to go through the process of treatment planning. Right. Thank you for listening.